Professor Gupta, Bharti. Hello.
You recognize the name, Victor. I recognize it too.
Uday, yes. Professor Gupta, Bharti.
Hello.
Hello.
Welcome.
Hi.
Okay, one more thing to do, then we'll be rolling.
And where are you from, Professor Atta?
Hello.
John Bennett. John Bennett, look at this.
Yeah.
Florida.
Oh, Florida.
Professor Bennett.
Hold on, Vic. I'm just getting things ready here.
You see my cup.
Okay, here we go. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon. This is Dr. John Bennett broadcasting from beautiful Miami Beach. We have today a webcast from Geneva-based neurosurgeon, Dr. Atta Bhatti. He is going to give a lecture today on human cerebral vascular developments, embryology, showing complex process of vascular tree formation in the human embryo. And we're also graced by the presence of Victor Hugo Perez, a world-renowned neuroanatomist, to help round up the talk. Okay, very good. Okay, Atta, it's all yours.
Hi, everyone. Can you see
Yeah,
me? Can you hear me?
Yeah, I can hear you fine.
So, can we start?
Sure.
Should we wait or can we start? John, can we start?
Okay, I'll introduce you again. Okay, hold on. I'll edit this out. Hi, this is Dr. John Bennett broadcasting from Miami Beach. Today we have another in the series of the Neuro Healthcare for LMIC with the head of that organization, Atta Bhatti. And today he's going to be lecturing on human cerebral vascular development, embryology, showing complex process of vascular tree formation in the human embryo. And we're graced by the presence of guest Victor Hugo Perez, a world-renowned neuroanatomist from Mexico City. He's going to provide some commentary. Okay, welcome, Atta. It's all yours.
Yeah, thank you, John. Thank you, Victor, and I'm Ata Bhatti. I'm a hybrid trained neurosurgeon and founder of Neuro Healthcare for LMIC. Today, we are uh, going through the neuroembryology, the basic one for human cerebrovascular development. And as we know, it's a very important domain for neuroclinicians, neurovascular, neurointerventional people. And as the field is advancing, the necessity of being very clear about the basic concepts of development are becoming essential for a practitioner to take various decisions during the dealing of pathologies they come across in their routine practice. And the purpose of this module is to give a basic review, and then we pick the each and every area differently to go further in details. It's meant to be for junior medical students and junior faculty neurosurgeons, and we are trying to as we are trying to address the new generation of medical students and neuro aspirants as well. So, as we know that the embryonic period starts from the third week until the 8th week. So these are the very dynamic period of human growing embryo, and there are different cavity formations which we reviewed in the last segment, the 3 cavity and then 5 cavity formation. As we see that the prosencephalon, mesencephalon, and the rhombencephalon. So
Excuse
we
me,
see the
Dr.
growing
Atta,
embryo
Dr.
right
Atta,
starting from the 4 to 5 uh, showing the different flexures, the cervical flexure, rhombic flexure, and the
excuse me,
initial
Dr.
development
Bhatti,
is more focused on
you're not, it's not moving. The PowerPoint, you're not connected to the PowerPoint.
sorry.
You want to move it's not moving. The slides are not moving.
Okay,
They're not moving. You gotta,
sorry. Now
you want to move the slides, right? They're not moving.
sorry. Can you hear me?
Yes, but the slide, you're still on the first slide.
Yeah.
Yeah, yeah, I see that, Uday. Yeah, the slides aren't moving.
Right, let me check it. And
You can click on the right side of the screen. That'll move it forward. Just click
yes,
on the right side of the screen. That should move the slide forward.
yes, I'm
The
on the
right
title
slide.
screen now. Can you see that?
Like we can see the first slide, but
Yes,
you
that's
want
title slide. I've
okay. It's
moved
still
to
on
the
the
second
first.
one.
Okay,
Yes.
okay.
So, driven by the changing spatial and temporal metabolic needs, the growing embryo shows the different changes, and they are dynamic in initial weeks. And this is very complex, yet well characterized and coordinated process. And during the first half of the century, 20th century, Paget has written a beautiful publication which had reviewed the Carnegie collection and provided a great deal of information about embryological development of the craniofacial arteries. And as we know that we have to go through the different basic things, the bronchial arches, the ventral and dorsal aorta, longitudinal neural arches, aortic arches and major vascular development concepts. We also will see some patterns of stapedial and ophthalmic system formation. And there are carotid basilar connections, which we'll try to briefly see. And also, we try to apply the ICA segmental review. In this slide, we can see the 5th week embryo, when a lot of things are already happened in terms of bronchial arches, brachial arches formation, and the initial vascular tree formation. And by the 8 weeks, the embryo has almost adult-like configuration of the vascular system. Although till birth a lot other things happens elsewhere, but the basic neurovascular structure, the vascular formation, is pretty advanced at the end of the embryonic period. So above you see on the left side of the slide, you see the vascular complex vascular structure that is from the work of University of Zurich and Irchel University, and it was done by the neurovascular team there, Long and Walabani's group, and this is still present in the Irchel Museum, showing the arterial side, the external carotid branches, the maxillary, the internal carotid, occipital, and vertebral. They are visible in this preserved actual model, which is in the Anatomy Museum of Irchel University and University of Zurich Museum. And at this work was done in 1970s. And on the left side of the screen, you see another beautiful diagram by the Roth, the illustrator in University of Zurich Hospital, working with the Yashirgil and then Walabanis. And he tried to demonstrate the different interactions between the collaterals, between the EC, IC, between the various branches, to show how complex vascular interaction is. And it's not only the cerebral of circle of Willis, which has various anastomosis, but it's the anastomosis levels are much more broader, and at times like internal maxillary and ascending pharyngeal connections, EC, IC, between the branches of the internal carotid, and between the branches of internal carotid and external carotid, there are, for example, ILT making some connections which are not visible in one run, but at times when there is a neurointervention procedure, at that time you see the shifting of that flow leads to the appearance of those opening connections. So the human vascular tree formation was done initially by the Lasdonias during the 2000 and before 90s, when he has some wonderful reviews of the previous work, and Pierre Lasdonias tried to give segmental concepts of the different growing embryos, and making the new lights on the angiogenesis, vasculogenesis, and remodeling. And he also mentioned some key points very important for neurointervention and neurovascular people. He had a background of neuroembryology and neuroanatomy, he was one of the most famous pediatric neurointervention pers a professional, and his textbook in the form of neuroangiography textbook is the most important book in the neurointerventional armamentarium. And under the influence of various factors, the growing embryo has a dynamic growth, and that segmental specificity is time bound, and during those dynamic phases, the identity and described pattern of specific segments growing into different forms. There is a lot of dynamic things happening, like growth of the vascular tree, the annexation of some arches, some regression of branches, and a lot of new vessel formation, and a lot of regression in the initial formation. It was based on different factors, like the growth factors, the most important VEGF, and there is genetic influence, and the specificity of time, trigger, and vulnerability was the concept he gave to explain why various pathologies, they don't appear in one time, and they can trigger in the consequence of uh, some uh, some dynamic insult at the specific timing, and leading to different manifestation of pathologies. So angiogenesis is the formation of different vascular structures, vascular tree, which is one time, and the vasculogenesis is the process which is like a dynamic process throughout the adult life, and it is based on the wear and tear processes, and in a way that there are some vasculogenesis processes which happens due to the repair phenomena, which we call as the remodeling, and the other one is constant changing of the vascular tree, and every 7 to 10 years you see a different sort of endothelial appearance, and this vasculogenesis becomes more active in the pediatric population, and as we advance in the age, this process becomes little slow down. So in this we are going back to the stage 14, where the 35 somites embryo, showing the very important structures, like the pouches. You see the bronchial clefts, 1, 2, 3, 4. You see the maxillary and mandibular processes, the auditory and palatine and nasal placodes, frontonasal prominence is visible. So this happens right at the rostrum, where the facial head and neck region is showing the bronchial arch 1, 2, 3, and 4. The first bronchial arch is also called as the maxillomandibular arch, and the second one is called as the Hyde, and then the third and fourth. This starts this process of formation of these arches, which we call as the pharyngeal arches. They are usually first, second, third, fourth, and sixth. It starts in the early phases by 24th day. So the first pair of pharyngeal arches, also called as the maxillomandibular, appears first of all, and then we see the height or second arch development below the first. We can see that this one, so which is also called as the Hyde arch. So the first aortic arch are plexiform vessels. So as we mentioned that there is a lot of neogenesis, the lake-like islands formation initially, and then endothelialization, and that dynamic vascular formation happens right in the head and neck area. So the second arch appears at the day 26, around day 25, 26. And by that time, the first pair of arch starts disappearing, regressing. The third and fourth aortic arches appears little later on day 28. And by the day 29, the first and second arches have largely disappeared. So the proximal end of the second arches, the proximal end of you can see the heart, liver, and upper limb buds visible, and this is in the neck area, almost the neck area of the growing embryo, and the flexure is also visible here. And each arch has a characteristic different endocrine gland also. So you see the parathyroid gland, exocrine gland, the palatine, auditory, and these clefts are also closely associated. Each has its own artery and its own cartilage and muscles, which we can see in the next table. So like we saw, the first maxillary mandibular arch, which is called as the first arch, developed at the 24th age, 24 days of the growing embryo. So each has its own nerve. So trigeminal nerve is associated with this maxillary artery, and the neural crest develops into mandible, maxilla, malleus, and incus. So the muscle of mastications, mylohyoid, tensor, anterior belly of digestic are the growth extension of this first pharyngeal arch. The second has its component of seventh fascial. It's called as the hyoid, and it has the stapedial and corticotympanic branches of the arteries. In the growing embryo is stapedial initially, and then after the regression and formation of different new connections, the corticotympanic artery develops in the adult. So the stapes styloid process, lesser conum of hyoid, and upper body of hyoid bone is linked to the second pharyngeal arch. And similarly, the facial muscles. So the just like the trigeminal nerve and the muscle of mastication have a same maxillary mandibular pharyngeal arch, so we can understand that how trigeminal nerve is linked to the muscle of mastication. And similarly, the facial nerve has a facial nerve supply of the muscles of expression, and all the muscle of expression plus stapedius, stylohyoid, posterior belly of digestic. So this is how the mesodermal cells, which are destined to become the part of head and neck, has symmetrical, coordinated, complex growth in a fashion that the nerve and related cartilage muscles are going to identify and grow together and have a later close association of function. So the third and the fourth pharyngeal arches what we call as third as a association of glossopharyngeal or ninth nerve, and fourth has a vagus or vagus and superior laryngeal branch. So the third has common carotid and internal carotid artery development from the cells of origin from the pharyngeal arch of the third, and the greater carno of Hyde and stylopharyngeus muscle is being supplied by the glossopharyngeal nerve. So similarly, the fourth pharyngeal arch has a vagus nerve and superior laryngeal branch, and cricothyroid soft palate. So it has a very broader function. The vagus nerve has a many organ function supply, and as we say that the this forms the part of aortic arch on the left side, this fourth pharyngeal arch, and partly the right subclavian artery is formed by the fourth pharyngeal arch. Similarly, the thyroid, cricoid, arytenoid, corniculate, and cuneiform cartilages are formed by the neural crest cells associated to the fourth pharyngeal arch. And we see the recurrent laryngeal branch. So the fifth is either rudimentary or not present, and usually it's number 6 is the next to the fourth pharyngeal arch, and the larynx and intrinsic muscles except the cricothyroid muscles are linked to the sixth one. Now in this slide we see the early embryonic stage. We see the regression of the first arch, which is what we call as the primitive mandibular artery. So initially we see the two heart-like structure. So the arc on the left and on the right, and here you see the cervical segmental arteries starting from 1 to 7, and seventh one forms the supreme intercostal artery later on. So we see the first primitive mandibular artery by the pharyngeal arch is the 4 or 5 millimeter embryo, where we can see this dynamic thing happening, where the first primitive arch regresses and the primitive mandibular artery stem is visible here, and the second also regresses and forms the hyoid artery, the forerunner of the hyoid artery. So the first aortic arch in the longer run in the adults forms the median artery, and the second becomes a hyoid artery in embryo, and then after a series of sequential changes, it forms the corticotympanic artery in the adults. So in this slide, you see the same thing happening. So here I would take little time to explain the ventral arch, the two dorsal, the ventral aorta, the two dorsal aorta, and longitudinal neural arches. So this ventral aorta will eventually forms the part of the carotid system. So this will proximally become the common carotid artery, and after we see the olfactory artery and the dorsal ophthalmic artery system. So the primitive mandibular artery is visible here. So the anterior circulation is mainly formed here by the ventral pharyngeal artery. The hyoid artery, we see the regressed here, and the primitive mandibular artery regressed here, and the primitive two longitudinal arches, they combine to form eventually the basilar artery. So the longitudinal artery, there are two longitudinal neural arches and two dorsal aorta. The two dorsal the two dorsal longitudinal aortic structures, the tubular structures, and beneath that you see the neural tube uh, having the parallel growth in the form of the flexures, the bending, and more on the rhombocephalic side. This coordinated concomitant growth happens similarly. So the longitudinal arch, the primitive mandibular artery, maxillary artery. So the first one, the primitive mandibular artery, maxillary artery, initially can be seen connected to the olfactory artery in continuation, but later there are some changes in the annexation and regression, and that leads to a different composition. So we can also see the cervical segmental intersegmental branches which are in the initial phases. So distal ventral aorta becomes the ventral pharyngeal artery and contributes to the formation of ECA. So this is the ventral pharyngeal artery. This eventually forms the external carotid artery, and the proximal ventral aorta forms the common carotid artery. So here in this slide, we see that the remnant of the primitive mandibular artery are visible. The remnant of the this median artery, the remnant of primitive mandibular artery eventually forms the median artery. The hyoid artery forms the stapedial artery. We see the hyoid artery becoming the stapedial artery, and then stapedial artery has two further branches, the ventral branch, which eventually gives rise to the orbital branch, and the maxillomandibular division. So similarly, we see the ventral pharyngeal artery, which we saw in the previous diagram, which it becomes the external carotid artery. It annexed with the maxillomandibular division to further form the further joints, and further has you can see the stapedial artery branches and the maxillomandibular and supraorbital divisions. They eventually get the different form in the growing embryo at the later stages. So in the next, the ventral pharyngeal artery merges with the maxillomandibular division of the stapedial artery to form the external carotid artery. Here we see the external carotid artery formation and the branches of the external carotid artery. So the ventral pharyngeal artery annexed with the maxillary artery, or the first arch which regressed proximally, and this ventral pharyngeal artery joins the maxillary artery and then the middle meningeal artery to form the external carotid and the maxillary arteries. So here you see the orbital branch initially, which supplies the orbital pit and orbital growing apparatus. So later on, this is being replaced by the dorsal ophthalmic artery in later weeks of the development. The proximal stapedial artery regresses, and its remnant forms the corticotympanic and superior tympanic arteries. The proximal stapedial artery, so here you see the this thing happening. So the proximal stapedial artery regresses and its remnant forms the corticotympanic and superior tympanic arteries. Here you see the corticotympanic artery formation, and the superior tympanic artery is also visible here. So the dorsal branches of the supraorbital division develops into the middle meningeal artery. So in summary, the third branchial arch and the distal segment of the dorsal aorta in a 3 to 4 millimeter embryo, they initially starts forming the ICA component, and there are two divisions as we see, the anterior division and the posterior division. Anterior division eventually, this is the ICA, growing ICA, distally gives rise to, later gives rise to the anterior choroidal artery, anterior cerebral artery, and the middle cerebral artery. So the posterior division remains as posterior communicating artery, and this latter gives rise to posterior communicating, posterior choroidal and posterior cerebral artery. So this is where the P1 formation from the ICA. So the ICA has a successive embryological distinct segments, and the formation of ICA initially starts earlier than the posterior extension of PCOM artery. Sorry, the transitory branches of the ICA later joins the bilateral longitudinal neural arches, and at the age of 5 to 8 mm of the embryo, and both longitudinal neural arches join to form basilar artery, and basilar artery at the age of in the size of 7 to 12 millimeter embryo, the vertebral artery simultaneously on the 6th intersegmental artery. Below the vertebral artery, this subclavian artery formation happens from the 6th pharyngeal arch. So the longitudinal anastomosis between the upper cervical segment, the longitudinal arch, and vertebral artery, they are very important, eventually forming the basilar artery, and the both basilar artery eventually leads to the supply till the rhombencephalic growth, till the origin of the anterior inferior cerebellar artery. So the ICA posterior division eventually makes the posterior choroidal and posterior cerebral, and this is how this growth happens. So now if we see this Paget stage 1, which is 4 to 5 millimeter embryo, 30 days of age, and we see here that heart is formed, which is the heart tube, aortic sac, and anterior trunk. We can see the pulmonary artery formation. The size, you can imagine, this is the 4 millimeter embryo, and this is 2 months, so at the end of almost embryonic period. So by this size of embryo, this all vascular tree formation has already been completed. So we are talking about this Paget stage 1, in which the mainly we see in the stage 1, we mainly see the involution of first 2 aortic arches, mandibular and hyoid arteries, as we mentioned in earlier slides. So the internal carotid artery origin is visible here. We can also see the cranial divisions, and the forebrain carotid two divisions are visible. So this is the carotid mandibular. This is where the segmental arteries are visible. The C1, C2 to C7. These are the segmental branches, and this is the aortic sac and arterial trunk, and this is the ventral arch, which um, which uh, which eventually leads to the external carotid artery formation, distal external carotid artery formation, and the internal carotid artery terminally being seen in dividing into two branches, and the forebrain and optic vesicles are supplied and by the by the by the primitive maxillary artery branch and primary cranial division of the, here you see the primary cranial division of ICA, and here you see the primitive maxillary artery, and also the caudal division, which gives rise to the anterior choroidal artery. This is the Paget stage 1. In the Paget stage 2, there are little growth of the size in crown ramp length to 5 to 6 millimeter, and we here see the internal carotid artery join the bilateral longitudinal neural form and forms the posterior communicating artery. So the primitive ophthalmic artery, and you see the 8th, 9th, 11th, 12th, these are the cranial nerves component. And you see the pica visible, and ICA trunk is visible here, and you see that the primitive ophthalmic artery at the cranial division of the ICA is visible. So in the stage 3, when the embryo is around 10 mm, so 7 to 12 mm, so there are further developing system outlined by the in the AP. You see that the mandibular and height, they are regressed. So as we see, there is a pharyngeal arch 3rd and 4th visible, and segmental arteries are visible. So the ventral ICA structure is being seen here, further developed. Stem of anterior cerebral artery is visible, and anterior choroidal artery is visible. In the Paget stage 4, before that, we see that in the stage 3 and 4, we see the new stapedial branches and the hide artery formation, which we saw in the initial slide. So this advanced confrontation of vertebral artery and two primitive ophthalmic branches of the internal carotid arteries being seen. Here you see the hide artery and the mandibular artery. So the developing cranial nerves numbered 3 to 12 is also visible in this this stage of 3, Paget stage 3. So in the Paget stage 4, when the size of embryo is almost 12 to 13, we see the outer structure of embryo is outlined in yellow, and the developing nervous system is also seen here. So here we see the subclavian artery arising from the two from the 3rd and the 4th on the left side, and here you see more clearly on the left side the formation of subclavian, and also we see the two primitive ophthalmic branches of the ICA. So here you see the structure of the eye globe, and you see the primitive ophthalmic artery from the uh, terminal, one of the terminal ICA, internal carotid artery. This is the internal carotid artery that divides into two, and that gives rise to the branches of ophthalmic, primitive ophthalmic or early ophthalmic supply, which eventually changes to the more adult pattern. So in the stage 5 of the Paget, we see this is when the embryo is 16 to 18 millimeter and the age is 40 days. And you see that the developing nervous system has now seen more bulky. So you see the more focus on the rhombocephalic flexure. So the telencephalic growth is minimal. So the distal ICA branches are also identified, but the main focus is here on the ophthalmic artery supply, and this is also a concept which P. Alastonius given, that in the rostral ICA usually ends in the bifurcation. There are two branches of the terminal ICA in the growing embryo, and the rostral branch, which is what we saw here, is the adult. You can see here, and these are the terminal branches. So the ICA ends at the bifurcation into rostral branches. The adult distal to the PCOM artery, anterior choroidal artery, and anterior cerebral artery. This is what we see here, posterior choroidal, and we see the PCOM and part of basilar artery. So the flow of ICA in a growing embryo covers till the distal basilar, till the ICA origin segment of the basilar. So this is when the developing nervous system is further defined in the pharyngeal. We see the further growth leads to the more defined ventral, dorsal and ventral vessels. So now we see the common carotid artery from the proximal most segment here, and then we see the internal carotid, maxillary, internal maxillary, lingual, and the branches of the external carotid. So the internal maxillary is one of the most important at this stage, and the internal carotid you see here divides into two. Now at this stage of stage 6, 20 to 24 millimeter embryo, you can see the anterior cerebral artery and the telencephalic growth of the brain in the 6th stage of Paget, and 25 mm of embryo at 45 days. So we can also see that MCA, there is also a discussion of phylogenetic origin. So from the perspective of the phylogeny, the anterior cerebral artery is an older branch. So the MCA grow little later. So and this MCA is actually the branch of the anterior cerebral artery. The phylogenetic acquisition of MCA is sort of a collateral branch of anterior cerebral artery. So this is contrary to what we see, that the internal carotid artery divides into two terminal branches, MCA, ACA. So for the phylogenetic, I mean, when we see the fish as a phylogenetically old system of vascularity of the embryo, it shows the presence of internal carotid artery and the two branches. One is the terminal anterior choroidal, and the other anterior in the form of providing supply to the ophthalmic and olfactory systems. So that anterior choroidal level later on in the rostral, this there are two branches of the ICA. What we see in this time, the caudal branch of ICA reaches the cephalic end of the ipsilateral ventral neural artery, and so this leads to the regression of pre-existing transient keratobasallar anastomosis. So what happens initially is that the ICA has the terminal two branches, one which are in the form of anterior choroidal, and then the rostral branch is one which is also called as the telencephalic branch. This is the rostral one, which later on supplies the ACA, anterior choroidal, and all the new telencephalic growth. And the dorsal one, which we see here, this is the PCOM artery, which has the superior most connection between the two systems, the posterior circulation and the anterior circulation. And PCOM artery is PCOM artery, posterior communicating artery, has partly the posterior cerebral artery feeder, and while the P2, P3, P4, they are being or arise from the lateral branches of the anterior choroidal arteries. So this is how this morphogenic and phylogenetic connection is. So the ACA is an older vessel than the MCA. MCA is for the new growing brain and the telencephalic growth extension of the ACA. So similarly, in the further stage, stage 6, what we see is that the ophthalmic branches are very particular. So the stapedial and the two secondary anastomosis of the major divisions are also visible, and now the ophthalmic system is completed in the Paget stage 6, and the middle and meningeal artery is also stem of middle meningeal artery is here visible, and primitive olfactory arteries and anterior perforated substances are very defined ACA. So ACA is visible, MCA is visible, and you see almost all the main vessels. Here you see the superior cerebellar artery. Here you see all the cranial nerves in the yellow, and the pica, ica, and basilar system. So the C1 segmental branches, C1 to C7, subclavian artery, aortic arch. These all are formed in a 2 to 2.5 centimeter old size embryo, 45 days old. In the stage 6, you can recognize almost all the adult form of the vessels. You see the external carotid branches. You see the ophthalmic stem, which is the which is the definite supply, and it's arising from the internal carotid artery. So you see the ophthalmic taking over the previous form of the primitive supply, which was from the pharyngeal system from the anteriorly, and now this stem of ophthalmic artery arising from the internal carotid artery uh, at the petrous stage. So we have to consider that the vasculogenesis is one time uh, process, and angiogenesis is a constant process, and this all uh, process in the embryo is dynamic under the influence of different growth factors like vascular endothelial growth factor, angiotensin 1, 2, tissue growth factors. uh, these are important uh, influence at the particular stage, leading to the progenitor mesodermal origin cells into formation of the primitive vascular network, and then the maturation is leading to the destination of particular cells into artery and veins. And here the angiogenic factor 1 and 2 and SIPs are important to determine the which vascular network is going to be artery, arterial capillary, or vein formation. And this is what we call as the maturation of mural cells under the influence of different growth factors. And this vasculogenesis and angiogenesis is a process in which the endothelial cells differentiate and proliferate within a avascular tissue and coalesce and form a tubular network initially. Aorta, major veins, plexus are there. Uh, this angiogenic remodeling network is defined by the processes of pruning, vessel enlargement, annexation, regression process under the influence of different factors. And this is how the eventual integration of endothelial cells, the smooth muscle cells, and pericytes happen to form the vessel wall. So there is a difference of endothelial cells in the head and neck area. They are derived from the neural tube. Unlike to other parts in the limb and other abdominal vessels, the neural tube, mesenchymal neural tube cells, the progenitor cells directly goes to the head and neck area, and the angiogenic formation and the vessel wall characteristics are very different than the peripheral one. So the vessel wall, the reactivity, the cranial nerve distribution, this is completely a separate vascular external and internal carotid artery and head and neck vessels compared to the peripheral one. So here we the same process like the vasculogenesis and angiogenesis on the top are visible. So the primary division, metameric division, and the territorial. So the supply, the how the different vessels identify that where to go and give the blood supply. That process is dependent on the demand of the growing embryo. So the territorial needs, like there are certain principles in anatomy and angiography which are very important to know, like the artery cannot exist without its territory. So first of all, any embryonic vessel which arises during the development from the pharyngeal arches, this vessel cannot disappear completely unless its territory does so, which never happens in normal situations. If there is a major insult to the growing embryo, then it can happen. So the embryonic vessels are there, they grow, they keep directions. There are variations based on the different patterns and different different variations are the result of those patterns. So an artery cannot exist without its territory. These are the few principles. In anatomy, embryo, and angiographic studies, we can see that when we see the CT scan, when we see the DSA and hunting for the disease process, these clues can give us more clarity, like the orifice or the foramens are not there if the artery is not there. So that's how if the orifice is not visible and the vessel is not visible, we will not take that as a occluded vessel. We will consider it as a inborn absent or hyperplastic vessel, and if the vessel was not there, the foramen will never develop. If the vessel secondarily get like a dissection and obliteration due to a pathology, then the foramen would be present. So the no vessel penetrates a bone except through an orifice inside the cranial cavity. So there must be a opening, there must be a artery and vein in the foramen, and this process is very very organized, and we see the metameric representation. So each artery, vessel, nerve has its own tissues, cartilages. There is growth, uh, which is the angiogenic activity, remodeling. In embryo, it's an active process. In adult, it can be triggered if there is any insult, any lesion, any vascular malformation. The development, defect, and disease also has a patterns. So just like in the congenital lesions, they are not necessarily present at the birth. So they just like the neurofibromatosis, it's a genetic predisposition, and people can have neurofibromatosis related growths in second, third, fourth decades. Similarly, in the vascular development, so this primary division is, so as the embryo grow, the extent of damage becomes more focal. So in the primary, it can be very extensive. In the remodeling phase or the later angiogenetic phase, when the embryo is quite grown up in the embryonic period, the uh, chances of having uh, lesion probability would be less. So the clonal phenotypic, and this is how the genotypic and phenotypic manifestation, and this is dependent on the possibility of trigger during the developing embryo. So trigger can be in the form of any disease. Regression happens as a programmed way, what we call as apoptosis. And when the embryo is in the very initial days, the damage or the defect or disease can be more widespread. And as we see, the dysplastic familial or non-familial problems are more in the early phase of the embryonic development, and the focal problems like the unifocal lesions, they are more in the advanced stage of the embryonic growth. In this slide, we show, like we initially mentioned, the ventral pharyngeal arch and the two dorsal pharyngeal aortas, and the vertebrobasilar formation through the longitudinal neural arch leading to vertebral artery, and then basilar formation. So the anterior circulation in the form of two carotid, a pair of carotid, internal carotid, and the vertebrobasilar in the form of vertebrobasilar has connections, like in the ICA terminality, we saw that the posterior communicating artery at the circle of Willis level, you see the the trigeminal, the posterior communicating artery connecting the anterior and posterior circulation. So these are called as the carotid basilar vertebral connections or anastomosis. The posterior communication, normally in the form of posterior communicating artery is persistent. It can have aplastic, hypoplastic, dominant, non-dominant, incomplete. As we know that many of the circle of Willis have a deficient part. So the PCOM usually is the remnant connection. It can be absent on the one side, and in rare situations, the both PCOMs are absent. So besides the PCOM, there are developing embryo has 4 more connections in the form of trigeminal at the level of the carotid and the distal basilar. We can also see the aortic, which is very rare in clinical situation, aortic connection, hypoglossal artery. Growing embryo, these are very prominent, but they regress with the time. Sometimes they can have they can have a variable adult findings during the angiograms or CT MRI. So these proatlantal intersegmental arteries can be more seen, and the trigeminal artery is the most seen connection, remnant residual connection in the adult, but aortic and hypoglossal are very rare. So these are the channels which compensates the flow depending on the various stages of the embryonic growth. In the anterior form, we see that the ophthalmic artery has again derived from the different parts of the pharyngeal arches, and we divide the aortic, this internal carotid artery in 7 segments based on their origin. So the normal development of ICA from the 3rd aortic arch, as we seen before, the gross anatomy, that the C1 or extra, the longitudinal one after the bifurcation of carotid is the C1. Then the carotid canal is the C2, and the L-shaped C2 is the bony petrous part of the carotid, which we call as the C2, and the foramen of Lestrum area when the petrous bone to the petroclival ligament segment, and the cavernous part is called as C4, and you see the further clinoidal C5, and then you see the communicating C6 and C7 bifurcation zone. So you see the choroidal and the communicating segment. So C6, here is the C6, and you see the ophthalmic artery arising from this C6 ophthalmic segment. This is how this internal carotid artery is being divided into different segments, and there are many normal variants, and there are anomalies which are seen during the clinical studies. So the normal variant can be bifurcation, usually normally at the C4 vertebral level. It can be high or low. It can be medial from the common carotid artery. These can be normal variants. The anomalies can be absence, hypoplasia, duplication, fenestration, and this is the persistence of the carotico-basilar connections in the form of persistent trigeminal, the proatlantal arteries, etc. So here we see the same internal carotid. Initially, the ventral aorta has the three pharyngeal arch 1, arch 2, and arch 3. So this is in the initial formation of ICA, and here we see the terminal internal carotid by the dorsal aortic components, and here we see the pulmonary artery, and in the later stages there are regression of the stepedio uh, stapediomandibulomaxillary system and new annexations leading to the uh, um, leading to the formation of this shape of various segments of the internal carotid artery. You see the first and second arches are regressed, meningiomandibular and height, they are regress, and the internal carotid is extension is visible here, and the proximal primitive maxillary artery and trigeminal artery and the basilar connection, this connection is visible at this stage. And in the final mature stage, as we saw, that the external carotid bulb is visible, the segment 1 is the vertical one, and then there are the different segments based on the regression and the aortic arch pattern. Like here, between the mandibular first arch and the height, there is the third, or this is the petrous part of the petrous segment, and then similarly here we see the dorso-ophthalmic artery level, and then the actual ophthalmic artery, ventral ophthalmic artery. So this is how we characterized the segments of the internal carotid artery, and it has many clinical implications in different pathologies like aneurysms, the dural fistulas, and in this angiogram you see the same segments marked by the petrous part, the L-shaped petrous part, the petrous segment. The This is the petroclival ligament approximately. Here you see the S-shaped cavernous segment. Here you see the ophthalmic artery. So there are, I think we have to see that the growing embryo in the final stages, it at the end of the 2 months, it looks like the adult. Let me go back to the slide where I was showing the last stage. So, summarizing the final stages, the 40 millimeter embryo, like the 4 centimeter size, has all the adult components: the vertebral artery, internal carotid artery, common carotid artery. There is already subclavian artery formation, ductus arteriosus and heart formation in this 4 centimeter structure. You see all the cartilages and cranial nerve structures. The branches of this basilar in the form of pica, they keep growing later, but they have a very defined adult stem present in the 40 embryo, and you see the and distal internal carotid artery in the telencephalic region, as well as the different ophthalmic and stapedial connections, annexations, and regressions, and you see that it's almost adult-like presentation of vascular status in the very tiny 40 millimeter structure, and this is so complex but very organized process, and any variation, understanding any insult any genetic predisposition leading to various vascular manifestations. It can be just hyperplasia, it can be a pediatric later age AV malformation, that the involvement of the segment and the trigger based on the and growing embryo and genetics can lead to the AVM presentation at later stage. I stop here and hello?
Yes, yes. Yes, we can hear you.
Yes, I can hear you.
Okay, all set? I think we lost him. But anyways, before we restart, when he returns, I'd like to introduce Bernd Dobler. He's a co-director. Hello, Bernd.
Hello, how are you?
Yeah, hi, let me get your face on the screen there. Okay,
Okay.
okay.
Yeah,
Yeah, but I just introduced Bernd. He's a co-director, right, Ata?
Yes, Dr. Van Dobler, neuroradiologist.
yes, I'm a neuroradiologist. I'm working here in Germany, and together with Atta, we founded our organization, and we are working on it to establish it and win new contributors and new members of the organization who can support us and help us to grow.
Yeah, we want to let people know who you are, and the website and the good stuff that both you guys are doing as well as your organization. Okay, let me just briefly introduce Victor. Victor, are you there?
Victor is trying to connect, but somehow he's
somehow
finding
Yes,
it
John,
difficult.
Yes, yes, I'm here.
Oh, okay.
Fitri.
Let me introduce Fitri. She's from an anesthesiologist from Indonesia.
Hello.
Welcome,
Hello, John.
Hi.
welcome, Fitri, and also
Hello, Professor.
I'd like to introduce Uday. Uday, you there? We had a conference and Victor's calling me now. Okay, any questions from the panelists? Let me hold on here. Victor's calling. Okay. Yeah, well, I'm not a neurosurgeon, but I'll ask this question anyways. Does a neurosurgeon run into a lot of anomalies that he would have been better prepared knowing a good embryological development of the vascular system? Is it that common that a neurosurgeon will see them?
Yeah, I think understanding development is vital to understand variations, to understand different pathologies at later stages. So as we saw that it starts from the folds and simple process becoming more and more complex and more precise. So having some pathology, some background of embryological stages and the configuration of different embryological patterns as well as morphogenesis, that helps us understanding different processes, different diseases processes, and to have a better and safe surgeon or neurointerventional people, because there are conditions in which the variations can make the pathology more difficult to anticipate, and when we do some interaction like having the internal carotid, external carotid channels, which can lead to uh, consequences if we for example, sacrifice some vessel, or if we are injecting a glue, So these variations are important. The processes of vascular territories and their different patterns are incompletely understood until we try to make ourselves better in developmental know-how. So it's necessary if we are a clinician.
Okay, very good. Oh, Uday, do you have any comments or anything you want to say? Are you there, Uday? You're not, you're muted. Sorry, Uday, you're muted. Okay, you don't have any comments, huh?
Just want to say it's an excellent talk. It's very informative and excellent talk.
Yeah, welcome. You're from India, correct? Uday? You're from India?
Yeah. Yes.
Okay. I won't guess. It's
It
the
was a very
biggest country in
informative talk.
America. Okay, very good. Okay, any more closing comments or questions before I make a few announcements? Okay, Atta, very good. Thank you very much. We're going to have part 3 of this embryological series next Tuesday. And I want to tell you guys about a couple of webinars coming up. Let me just try to get them here. I'm sure. Hold on, let me try to get it. Just give me a second. Now that I am presenting. Hold on, I have to get it somewhere else. Sorry, folks, to keep you delaying. Oh, okay. Oh, okay. Well, anyways, I'll put that on there.
John, maybe I have one question. Not question. It's maybe like a. We can discuss about it or think about it, John.
Okay.
Atta is there?
Yes, I'm here.
Yeah,
Fidri?
Professor Atta. Yeah, Atta. Do you think if in the pregnancy if maybe one mother wants to be an abortion to make abortion in the you said that the develop of the vascular is about the 3 week until 8 week. Is that correct? And then a mother wants to make an abortion. What kind of congenital disease can be happen to the baby?
See there are spontaneous abortion of up to 10%
Yeah, maybe a
conceivements.
spontaneous abortion or
So that's most likely in many cases if the neuronal development of embryo has some inserts during that, and it, as I showed you in one slide, that if the insult is initially, it's so incompatible with the life that nature takes care of it. And at each stage of development, right, starting from the tiny 4 millimeter embryo until the 8 weeks, of the embryo
Yes.
when the size is like 50 millimeter, around 5 centimeter. So the 5 centimeter embryo has almost adult-like stem of all the major vessels. So if there is a minor vascular variation problem, so what happens, as I mentioned, that the if embryonic vessel never disappears, so is the embryonic developing territory. But if, for example, there is a severe maternal infection leading to the regression of the growth of embryo, then in that case, the vessels also will regress. So
Mm.
it's a supply and demand sort of growth. So when the growth happens, there are secretion of different growth factors, and it's a vicinity tissue and the distal tissue. There are parallel things happening, and like if something happening on the prosencephalon and the telencephalic side, or the it's something happening at the aortic arch level, aortic level. So these are very regulated. So in the mesodermal cells, the initial cells which are going to become a vessel, they have a genetic tendency and programming
Mm.
that what they precisely will deal in terms of migrating in a certain place, in terms of branching, in terms of regression, or
Mhm.
so a lot of processes are involved, which leads to a coherent growth. If there is um, some inharmonious growth, then nowadays clinically ultrasound can pick it during that phase. So the 20
Mm.
days is the start of somites, and from the 20 days ultrasound can pick the age and length of the fetus, and the biochemical parameters can also pick the abnormalities of the neuronal cells, like the massive neural tube defects. As the embryo grows, you can get an information by the ultrasound for the any visible, for example, anencephaly, the myelomangosyle, like improper neural tube closure and things like. I hope I addressed the right uh, query. Is that
Yeah,
giving you
yeah,
the answer of what you asked?
yeah, yeah, yeah.
Mm.
Yeah,
Okay.
thank you for your thank you, Atta. Thank you.
Thanks for the question, Fitri.
Thank you for excellent lecture. Your excellent lecture.
Thanks for coming. Okay, any more comments or questions? As I mentioned before, Arthur's going to have another lecture next Tuesday, same time. And let me just tell you about a couple other events coming on around. We're going to have, this is part of the second lecture of the student group on Saturday at 7, Understanding Disc Herniation. And we'll be posting about that. You're all welcome to come. Okay, very good. Arthur, thanks a lot. And we'll
Thank you, John.
see you. Thanks,
Thank
Bern.
you, everybody.
Thanks, Uday, Fitri, for coming. And we'll see you next week. Bye-bye.
Bye bye. Bye bye.
Bye-bye.
See you.
Bye-bye. Okay, we're off the air.